Hi, welcome to Detours Understanding Acquired Brain Injury. Now, this is the third in the series of episodes devoted to the essentials of acquired brain injury, talking about traumatic brain injury and looking at some of the mechanisms and looking at, now for this one, long-term effects. Unfortunately, when it comes to long-term effects, they're really not well studied. And because really it's part of the problem stems from definitions, and part of it stems from, unfortunately, problems with funding, things like that. So we can only really talk in generalities. And, well, traumatic brain injury, acquired brain injury as a whole, should be thought of as a chronic illness and a systems illness. Now, what I mean by that is it isn't just a problem, an illness that affects one individual who's a survivor, but it affects their family and the community at large. So I'm going to talk about not only what happens to the individual as far as like the neuropathology, but I'm also going to be talking about how it affects the community and family and things like that quickly too. But first of all, long term, I'm talking about years and decades. I'm talking about the lifetime of the person, because it is a disease that affects people over their entire lives. As a survivor, a 30-year survivor myself, I've also had a second TBI, which was not as bad as the one that happened in 94. But it is something that casts a long shadow. It's not like an injury that affects like a broken leg, knee, like a joint injury, or even some conditions like ones that affect your heart, your lungs, or your liver, or something like that. Although many of those conditions do leave a lasting impact. But if you damage your brain or your spinal cord, which is part of the central nervous system, those kind of illnesses do have a lifetime effect on the individual, but usually they don't affect too much beyond the family as a whole. They don't, affect the community as a whole, unless it's something so devastating, like certain cardiac conditions, sure, CHF or something like that, where you're looking at needing a transplant, the person can't work anymore. It has to be extreme. But with brain injury, even a so-called mild TBI can take you out of the workplace or can alter your social connections and can change the way you interact, can in effect rewrite your operating system, who you are as your personality, because it is important to remember that personality is an emergent property. It's kind of like your operating system of your brain, to think of it that way. It is software. It is not, it is part of your brain. It is an aspect of a functioning brain. And so damage to your brain changes who you are. As far as usually what it does is it magnifies pre-existing traits or suppresses others. It's not like it is a complete out of nowhere problem or thing that happens. It is more like these are aspects and traits that you had, that your parents and your friends and yourself conditioned through behavioral techniques, which is why these are good techniques to help fix some of the problems, conditioned out of you through discipline. Sometimes good discipline, sometimes bad discipline. But usually these are already pre-existent traits that maybe, weren't as noticeable. Maybe you were really talkative or really didn't say much before, but you learn to be more social or whatever else through years of these kind of things, or you were maybe a little bit irritable or whatever before. Now it's really, really bad. So these things can be fixed with a lot of effort and hard work. The thing is, as an adult, a lot of these habits and behaviors, and then with cognitive problems on top of it, are much more difficult to fix. But yes, they can be addressed. Anyway, so shifting gears again back. So you have obviously the physical domain, where changes we may see long term include things like changes to your endocrine system and your general health, Why? Because your brain, the hypothalamus and the pituitary axis here, is a picture of like where the hypothalamus and pituitary are, the master gland, as it's commonly called, because its secretions regulate other endocrine glands, which are chemical signals in effect to other major organs in your body. And so if this is damaged due to traumatic brain injury, you will get inadequate signaling. People often will ask, why do I get sick more? Or why am I having diabetes? Why am I not healing from illness? Why am I having problems with bone growth or more fractures? Or why am I having like problems with pain? Or what? This is part of why. Because I'm having problems with signaling, because my hypothalamus or my pituitary is altered. You may have problems with things like more frequent urination or problems with digestion, bowel, nutrient absorption. And a part of it is hair. This signaling is disrupted. This neurological to chemical endocrine signaling is disrupted. And when that happens, and this usually happens over time, it's not something that is immediately after the injury, although it can be. More often this takes time to change because chemical signaling is slow. Also, the feedback between the hypothalamus and the brain relates to regulation of heart signal, heart rate and respiratory and things like that, and passes through the trigeminal nerve, which can be disrupted. And this is where you get the kind of neurostorming that we talked about. I'm going to talk about that separately in this whole area separately, but these are changes that happen over time. You also see pathological pain due to neurological injury, damage to the insula, which is, well, that's here. What's interesting is the insula also damage here, because this system of your brain, you've heard me talk about this before when I talk about problems with alexithymia, recognizing your own feels, your own emotions, and empathizing, the ability to recognize other people's feelings because you don't recognize your own. Well, damage to this area not only affects that, but also can affect your ability to recognize your own body sensations. It's not quite as cut and dry. The research is like, yeah, on that. So, but it definitely seems to be connected. Damage here affects control over your heart and your circulatory system. So people with injury here, this seems to be related to neurostorming, but also parasympathetic signaling too. So your heart may bottom out as well. Although usually in those cases, most people with a parasympathetic problem do not survive. There are rare cases, where they have, but significant damage to the left insula and damage to the hypothalamus and the parasympathetic nervous system can cause like drop. And any damage here with neurostorming, other things like that, for long term, again, this is a long term kind of effect. You may get what's called stressed heart or neurogenic cardiac syndrome. There are a lot of names for this thing because we're only starting to discover this, but stress heart. And it's got nothing to do with like simply being anxious or whatever. What they're talking about is, unlike primary heart disease, this has to do with failure of signaling between the brain and the heart, and they're not talking to each other. And it affects the vascular system as well. This is a long-term effect. And the heart is not pumping adequately because it's not receiving adequate signals for how strong it should pump, or its rate and rhythm, its timing signals. So, and just like in a car, if your engine is not getting signaling for how much fuel to put in and how often, and it's not going to run properly, and over time it does damage to the engine. Well, guess what? If your heart does not receive adequate signaling, your blood vessels, you'll have problems with eventually damage to your heart. So yes, traumatic brain injury can cause critical cardiac damage over time, and eventually it kills. So it's a matter of, one of the treatments for this condition is to put a pacemaker or a pacer defibrillator in. Brain injury can cause heart damage. Yeah, Strange, it seems, but yes, the two are linked, and there are a number of, we're starting to discover this more and more. It also affects the respiratory rate. Now, that is much more quickly fatal if this is a critical problem. It affects digestion, again, through similar signaling mechanisms between those areas of the brain. And again, usually a person who has, and you could tell, people with the alexithymia, the problems with empathizing and feeling, because you need body signals to help you recognize your own or generate your own emotions and communications to the amygdala. So usually a person who has trouble with empathy usually also has problems with their organ systems, because interestingly enough, these systems are connected. You need to get your own body feelings, your bodily sensations, to recognize your own emotions. The two are linked. Emotions are a recognition of how you feel inside. And if those two signals are disrupted, you've got problems with that. So often that's a good gauge. What's also interesting and related to this is if you, people who describe, they misinterpret physical pain that is actually emotional pain. They have problems. They think that their bodily aches and pains are physical when they're emotional, because they're having problems with the amygdala and misrecognition of what are like sadness, anger, whatever, and they'll interpret that as physical pain. Damage to the insula. So if there's imaging done and you can see there's changes to the volume density of the insula over time, there's a good chance that they're not recognizing their own anger, depression, whatever else. And there are fortunately QEEGs that can be done to train the person. Oh, when you feel this, you are feeling this. And then like looking at their own expressions and things like that, because their face will still show expressions. But again, this is long-term training. And they need to be taught to recognize others people's faces and perhaps be able to induce sensations in them. But this is deep brain kind of thing, and these are long-term effects, physical effects. There's some studies that suggest cancer. This is kind of iffy, but brain cancer, gliomas, are more likely in people with traumatic brain injury physiologically, because of problems with signaling, DNA and RNA reading. And so over time, that cancers are more likely. Diabetes is more common, again, because of hormonal linkage. These are small changes in probability, but these are things to be to take note of. And I'm going to be like looking at the research, but these are also things that we see changes in. Social factors. With a frontal lobe or temporal lobe injury, over time, it's like we have trouble with our social skills. Anosognosia, lack of recognition of what's wrong. We do poorly, not everybody, but a lot of people with, especially with frontal lobe damage to the medial areas. It's not denial, it's our feedback tells our brain we're fine, that we're doing great, even if we are making everybody around us angry, depressed, frustrated, because we tend to be more apathetic, so uninterested in the world around us. We kind of blank out. It's related to adynamia, which is a lack of willpower. It's not laziness. It's kind of like a car with its engine running, and you can't shift into gear. You can't get moving. You want to, you can tell everybody what your plans are, but when it comes to putting things into action, you can't. A lot of the elderly with dementia, Alzheimer's, stuff like that, you see them like kind of just staring. Yeah, that's what adynamia is, that kind of blank, there's nobody home kind of thing. And speaking of dementia, that is something else that is common, 3 to 5 times more likely in us. And the more traumatic brain injuries you get, whether it's mild, moderate, or severe, it doesn't matter. In fact, the mild ones put us at much higher risk for Alzheimer's, frontotemporal dementia, and for the one that's kind of more unique to us, chronic traumatic encephalopathy, CTE, or, traumatic encephalopathy. Yeah, here are the list of symptoms for traumatic encephalopathy, which now does have criteria for the living. But some of the things are similar to Alzheimer's. This is one of the ones that scares me the most, is because it's really hard initially to separate it out from just your day-to-day symptoms. But this one is one of the ones where I look and I go, our brains atrophy over time. Our brains shrink to begin with as we age in 30s, 40s, 50s, 60s, throughout life. But with traumatic brain injury, even mild TBI, every year after we have one until it's stable, as far as from the trauma, our brains atrophy and we lose function because our brains shrink. That's for everybody with traumatic brain injury. Our brains shrink because we lose parenchyma, brain tissue. Those neurons that were initially injured, that those that are going to die eventually do. Many times they die off because they're injured, and so they self-destruct, the apoptosis I talked about. And so this is where a lot of people wear, encephalomalacia we'll talk about. So basically what that is focal areas. Here's I'll put this up. Encephalomalacia is a progressive die-off of focal areas initially, which were bruised, which usually are all throughout the brain, and closed head injury and TBI. And it progresses at least for a couple months to maybe a year or so until it's stable. But this is part of brain atrophy, but it happens to all of us. Some degree of encephalomalacia, some people far more serious, and encephalomalacia means softening of the brain, but the white matter that is lost, as well as the neurons themselves that die through Wallerian degeneration. There's also the ongoing neuroinflammation. Once the large cells that got through the broken blood-brain barrier are in there, they're in there, and the blood-brain barrier takes a long time to heal. So we keep getting inflammatory factors, the cytokines, the microsnippets of DNA, all that stuff remains. All of it remains. So yeah. Anytime there's a significant emotional stressor, physical stressor, whatever, that does more damage to our brain. Psychiatric conditions are far more common in us. Both some of the personality disorders, we display the traits, and this is something important to address also. A person who does not carry a psych diagnosis before, they're not going to be given that, they can't be given that diagnosis after, unless it can be shown that it was something they were exhibiting before. What they'll be done is they will be given, personality change due to traumatic brain injury or acquired brain injury, whatever their condition is, according to DSM-5 TR. Even if they have all the traits, like I said, personality disorder, you can argue, like major depressive disorder, things like that, which, by the way, depression and anxiety, we are 8 times more likely to develop depression, 6 times more likely to develop anxiety long term. But it is important to distinguish apathy, which is pseudo-depression, from depression. And apathy is simply like not caring. And one of the ways you can tell is like they don't have that low mood. It's more just a flat response. And that also applies, a lot of them will say it's like I'm calmer, more relaxed. No, because you see that it applies to things they like to do as well as, and it is long term, and it applies to themselves as well. It isn't just with regards to others, but it's themselves. They don't take care of their own grooming. They don't want to go out. They don't want, you've got to jab up. And that's more of an emotional, the emotional side of adynamia. Nothing animates them. Now understand, these are all on a spectrum. There are the extreme cases, basically, that you see in the nursing homes. And then there are the milder cases where they'll just have like brief moments like this where it's like, hey, yo. And then there are those in the middle who are like sometimes yes, sometimes no. And so it almost seems like you get different people each time. And that's because, it's like, something does, something doesn't. And those almost seem intentional, but they're not. It's just neurology works differently for different people. You've seen one brain injury, you've seen one brain injury. Each person is unique. And there are treatments for a lot of this stuff. A lot of the rehab and things like that is just plain old-fashioned straight psychology, because how we learn to be who and what we are is through behavioral techniques. Reinforcement of good behavior, withdraw attention for negative behavior, and yes, sometimes medications. That's a whole, neuropharmacology is a whole different thing. And time, too. It's not all downhill. Yes, each person's progress is different. The majority of people over time tend to stay about where they are after they were about 5 years. So after about 5 years, what you got is what you got, usually. But there are some who continue to improve. And note, I'm not saying they don't recover, get better, but what I am saying is the disabilities that you have are the disabilities you're going to have. Can these improve? Can you be less adynamic? Can you be less, can you have less trouble with word finding? Yes, and that will get better. However, you will always have trouble with word finding, adynamia, apathy, whatever. It'll always be there. Its severity will change, but you'll always have problems with that. Irritability, emotional lability, there'll always be disabilities you have, but you can improve them. I think that's also one of the problems people have in understanding, says, after 2 years, you never get... The disabilities you have are going to be fixed at some point, but you can do better with them through, learning and getting getting other neurons through neuroplasticity to take over the role and to help. It's kind of like if you have a company or something and you lay off half your workforce. Well, the other half's going to have to pick up a lot, and they may not be as good at, making widgets as they were at managing the office, but they can kind of do it. But you'll always have some trouble, and they'll get better and better at widget making, but they may not be the master widget makers you ended up, half laying off, And so that's kind of the situation there. Obviously, as you age, you'll have the problems of aging combined with your brain injury. These are the long-term effects. Research is ongoing. Can you get worse, or can symptoms suddenly show up? 20 years after your TBI, you thought you were doing great? Yeah, symptoms can show up after that. Sure. In many cases, you were just compensating really well. In those unique cases. Community-wise, a lot of people, they lose friends and connections. Oftentimes what happens is friends and supports and they expect you to heal like you were never injured. It's treated like a broken leg, or, oh my God, they lived through the hospital stay. But now, what are they doing? Why are they still having problems? Or these new deficits, they don't seem to want to go out as much. They don't get it. And they drift away. And this takes a couple of years before it happens, and you end up having to make new connections. And we find that the number one complaint of most of us, loneliness. We've got a problem with loneliness. It's the number one of all complaints after brain injury. 5 or 6 years afterwards, 7 years, we don't have the connections. And those who do stay or build are good at dealing with emotional or like mental health problems, or are other survivors who recognize in themselves. This is why survivors groups are so important. And that's one of the solutions, because you see people like yourself, and believe me, we come from all walks of life, and 1 in 20 people have acquired brain injury and with permanent symptoms. That is a lot of people. 1 in 20 out there. If you just walk down the street and count 20 people, one of them, including yourself, but you count off 20 people, one of those people besides yourself has permanent neurological impairment due to acquired brain injury. A buttload of people. And 1 in 60 has traumatic brain injury. That is a buttload of people. So keep this in mind. You're most definitely not alone, but it's like loneliness because most of the time because of social problems, because of this kind of apathy and irritability and negative attribution biases and that callousness, that self-centeredness, and some of the really bad traits that would, if it weren't for brain injury, you'd just call a person with these traits a jerk. And that is also something. There's stuff you can do, but you have to want to do it. There's rehab, and there are ways to treat these social deficits, but you got to want to do it. And that takes courage to face your own disabilities. It's easier to blame everybody else. But as the saying goes, if you're looking for the person who's crazy or the person whatever, and you can't find it in your family, or you think they all are, that's you who's the problem. That's a simple tip. And that's a tip for survivors, family members as well. It's like, if you're blaming everybody else for every single problem there is, they're the problem. And you as the survivor, if you think it's everybody else, it's you. It's you. And it's time to get a little help. It's okay. It's what happens with brain injury to a lot of people, especially frontal lobe injuries. Not everything. And again, most things are along the spectrum. There are very mild cases of this, and there are really severe cases. The most severe cases, sadly, end up in nursing homes because nobody can deal with it. Not showing gratitude, not returning favors, not doing things to help other people makes them not like you. That simple. Everything can't be about you. Everything can't be you-centric. That's how life goes. It's it's transactional, unfortunately. Quid pro quo. That's how it's got to be. Yeah, I always throw some of that in there just because it's important to remind us, myself, and fellow survivors that it takes two to tango. All right. That kind of brings to an end our series on the essentials and the basics, because there's not a whole lot of research on long-term effects. We just know there's some heavy-duty stuff, and we know it affects employment because a lot of employers don't take back employees who are out for that long and that are impaired socially. That is the number one killer of being able to come back. And those who do come back are often in a lower position, aren't able to work as long, or have angered customers, clients, because, again, that self-focus. So it's a problem. And so they find it very difficult, or they don't progress and they don't move forward in their job. They're at the very bottom level where, even if they're a highly skilled worker, if you're an engineer, an accountant, nurse, doctor, whatever, you remain at the bottom spot because no social skills and cognitive impairments. Because a lot of the social skills are based on cognition. How well you understand yourself and how well you understand the other. And we know that not only doesn't get better, many times it gets worse over time without appropriate therapy. This is part of why wind up kind of isolated too. All right, yay, enough happy news. Actually, a lot of people, the majority, end up kind of when it comes to happiness. And some people find, here's, I would argue, the key. Finding purpose. This takes time, but survivors who report the greatest happiness and the greatest well-being and do the best socially have purpose. They found why, what their purpose is in life. Have they discovered art skills? Have they discovered they're going to be, strong advocates? Have they discovered that they're a voice for the disabled in some way? Political involvement. Have they discovered that they are, a strong voice for, their faith? I don't know. Whatever purpose they discover for themselves, and helping others. Those long-term, those are the things that not only bring happiness, but help with the discovery of meaning. And those are the survivors that do the best medically and, do the best as far as the studies show. By the way, one thing I did forget to put in, pre-existing. What happened before you were hurt? Did you have mental illness? That definitely affects in a negative direction what your outcome, both short and long term, look like. Gender. Unfortunately, ladies, you do worse than guys do. Even though guys have more traumatic brain injuries more frequently, ladies do worse. Check out Pink Divide, where I talk about why. If you're incarcerated, that socioeconomic status, people with less resources do worse. Education is kind of a split. Those with more education tend to recover better, but complain of more symptoms. I think it's because they're aware more of what they've lost and they notice more. And probably because they have higher level jobs, and therefore even a slight change sets them back. But they also have more cognitive reserve. They can afford to lose more. And any change for them has a more deleterious effect. Those seem to be the factors that affect. So please like, subscribe, hit that bell icon, please. And if you have any questions, anything else to add, please do. I'd love to hear from you. Any suggestions or anything else. In this series, next we'll be looking at toxic encephalopathy, which has a lot of things to connect similar with secondary impacts. But it has some of its own unique primary as well. And so hope you enjoyed that, and going to say bye and see you later. Hope you have a good day. Bye.